Welcome the rising nurses. We are going to talking about chronic kidney disease. This is what happens when there is permanent damage to the kidney and they are unable to recover their normal function. CKD is progressive irreversible loss of kidney function, usually evidenced by GFR less than 60 ml per minute. Normally, GFR should be over 90 ml per minute. When that happens, and the kidney can't filter the blood, you also lose the ability to remove fluid and toxins, control electrolytes, and regulate acid-base balance. Anything that could be affect the vascular system, blood flow to the kidneys, or the kidneys themselves can cause the patient to progress into chronic kidney disease. So that could be diabetes or hypertension may be occur. On acute kidney injury that does not get reversed, glomerulonephritis, or even autoimmune disease like lupus. This patient will eventually require dialysis because the kidney aren't functioning effectively, and as they get worse and their GFR will drops below 50 ml per minute. They will progressive into what we call end stage renal disease. We are going now what we really want to see in how much kidneys failing impacts every body system. As we going through this thing about the function of the kidney and what happens if they aren't working. First and foremost, we start to see azotemia. That's when those nitrogenous waste products are building up like blood urea nitrogen, creatinine, and urea in the bloodstream. And you will see how that alone cause a number of other issues in the cardiovascular system. We see volume overload because air aren't getting rid of the fluid like they should, that cause hypertension and can even lead to congestive heart failure if their heart can tolerate that kind of preload. We also see the lack of renin production for the renin angiotensin aldosterone system. That's another reason we can see hypertension in this patient. If you need to review on preload and heart failure, head over the cardiac course. Because of that same value overload, we can see pulmonary edema. So we will hear crackles and they may be shortness of breath. This volume overload and acetomia can also have neurological effects. We could see cerebral edema or even uremic encephalopathy. Patient could be confused, lethargic, or even slip into a coma. The other thing that affects neurological function is that patients tend to have metabolic acidosis. Their kidney aren't hanging onto the bicarb like they should, so their pH will drop way low. That can also cause some altered mental status. Now let's look at the few other symptoms. Remember that the kidney are responsible for making erythropoietin, which goes to the bone marrow to make new blood cells. So patients tend to be anemic and can even be thrombocytopenic, meaning they aren't making enough platelet either, decreased platelet. In the GI system, we see anorexia, nausea, vomiting. These are because of the metabolic acidosis, but also the acetomia. In general, it can cause GI discomfort. Honestly, patients just feel like poor. That excess urea, the blood can also cause some skin symptoms as well. One of the most common uremic priorities, itching. All they get so itchy. I have seen patients scratch themselves till they bled. They can also get something called uremic frost, which is when their skin gets these silvery flakes. We attached on the image of this lesson, so make sure they check out it. In the musculoskeletal system, we can see osteoporosis. In the musculoskeletal system, kidney patient tends to have low calcium levels. Speaking of electrolytes, we want to make it very clear what happens to four main electrolytes in chronic kidney disease. And really any form of kidney failure. First, in relationship between sodium and potassium. Normally, in the kidney, every time they retain sodium, they excrete potassium. When the kidney aren't working, they aren't able to hold on to the sodium like usually would. Sodium gets excreted in the urine. When that happens, it reverts to process and retain the excess amounts of potassium. So we see hyperkalemia and hyponatremia. High potassium puts patient at risk for EKG changes and cardiac abnormalities. When while hyponatremia can put them at risk for seizure, neither are good. The other set of electrolytes is calcium and phosphate. These also exist an inverse relationship. As one increase, the other decrease. Normally, the kidney do an excellent job of excreting phosphate that helps to ensure calcium levels stay sufficient. The problem in kidney failure is that does not excrete phosphate like it should. So our phosphate levels get elevated and in response our calcium get really low. As you will learn the endocrine course, that's when our parathyroid kicks in the begins, breaking down our bones to try to increase the calcium level. That's why we see brittle bones and osteoporosis, course and of course hypocalcemia can also cause muscle stretching or cramps. So you can see how integral the kidney are in making sure our entire body stays in balance and function normally. Our entire goal of their therapy is going to be work to restore this balance. We are going to end of having to take over the function of the kidney since they aren't working. One of the things we are going to is giving epitoin alpha. It is a synthetic form of erythropoietin and can help with anemia. We can also give diuretics to help flush toxins and fluids out of the system. But at some point, even the diuretics won't get the kidneys to do what we want. So we have to resort to dialysis. We will talk more about dialysis in the later session. But essentially, it is machine like what you see here that pulls the patient blood out of their system, runs it through a filter that's like an artificial kidney. It has a semi-permeable membrane and fluid solution in it that force all the electrolytes and waste products to diffuse out of the blood. This becomes their lifeline. Many patients get dialysis 3 days a week, every week for the rest of their lives. The last thing we see is the most important. We will work on managing and balancing their electrolytes. We give phosphate binder before meals to keep their phosphor low. In fact, it usually actually called phosphor low. They will also get calcium supplements to keep the normal. For potassium, there is a group of medication that will help to lower potassium. First is caxylate that binds it and excrete it in the stool, but it can take a bit of time. So we give calcium gluconate to help protect the heart while we work on lowering the potassium. The other medications we give are an insulin to help drive potassium into the cells. So it's not in the bloodstream. So we give the patients dextrose or D5, D50 percentage with it so their sugar doesn't bottom out. And lastly, we give albuterol. Oddly enough, beta agonist can also help shift potassium out of the bloodstream into the cell. Ultimately, the goal is to restore that normal balance of electrolyte and do what the kidneys can't. So, as you can guess, our top priority for the patient with CKD are fluid and electrolytes and elimination. but we also consider safety because patient may experience vision changes or peripheral neuropathy that could be put them at risk for falls. They could experience cardiac events because of the higher potassium level or if they are receiving dialysis. We need to make sure to keep their dialysis assets access safe and protect at the all time. It is their lifeline. Check out the care plan attached to this lesson to see more detailed nursing intervention and rationals. Kindly instruct the patient on dietary restrictions, sodium, potassium, and like fluids. Instruct the patient on dialysis, mm, chest pain, shortness of breath, severe itching, and excessive weight gain, more than 2 lbs per day, and more than 5 lbs per week. Don't forget the mnemonic AEIOU. A for acid base problems, E for electrolyte problems, I for intoxication, O for overload of fluids, U for uremic symptoms.